Briefly, I'm going to touch the topic, the basics, like indication, contraindication, we all know. Symptomatic patient with severe mitral stenosis, symptomatic patient with moderate to severe stenosis, asymptomatic patient with severe stenosis with significant pulmonary hypertension, carefully. Before pregnancy, for asymptomatic patient with severe stenosis who plans for pregnancy later on. Moreover, we have been doing in AFIC, RIC, lots of pregnant patients in the second trimester, where the gynecologist suggests 6 months have passed, we will unable to continue the pregnancy and we are going to terminate it. But the cardiologists at big center, they take the risk, and most of the cases we are successful and we save the patient from losing the fetus. But we have to select our patient very carefully. We have to know that we can't do it in a moderate to severe MR. Presence of severe calcification by commercial. Presence of concomitant aortic valve disease. Here, if we open the mitral valve, even then for aortic valve, especially aortic regurgitation will adverse and the treatment is not done. And in cases of mild mitral stenosis, which can be followed up with time. These are the basically angiographic views in which we go and do the procedure. Plain AP, LAO40, LAO40, RO40, and sometimes true lateral for puncture, septal puncture, as well as opening the valve. Instead of going into the details, this slide is commonly available. The first view is LAO, where we puncture, and we select a size, and normally if you are trained, so most of the time in more than 70-80% you are able to go through the fossa instead of active puncturing. So here in this view you have got heart on the right side and spine on the left side. You puncture and you go and you take the wire and then take the balloon and then you are going to inflate. I'll show you later on. So this is the procedure written in every textbook. This is what we intend to do it. Atrial puncture, balloon passing through to the LV and then inflation. We know about the basics from our medical school. This scoring system, 6-point scoring system. Favorable for PTMC 8 or less than 8. RIC started this in 2013, and these are the number of procedures per year, and 12 procedures in pregnancy has been all alhamdulillah successful. AFIC last 5 years data. AFIC has got a huge data and lots of operators available. And again in 12 pregnant patients it was done very successfully. Now I'm not here to teach how to do PTMC. I'm here to... Mitral stenosis is a disease of third world countries, and we should be more proactive in developing guidelines for its management. Instead of following West, our experience is very vast all over Pakistan, starting from Karachi, Peshawar, Lahore, Karachi. Lots of operators and lots of patients we have got and lots of experience. So we should know our technique and we should teach the world. Echo and TOE should be preferably performed by the operator himself or herself. जिसने procedure करना है वो खुद करे. Echo should be available on site during procedure in the cath lab. Very, very important. Echo should be repeated on the day of procedure as well. Sometimes what we see, 2 weeks earlier we did the echo, there was no thrombus. But before, on the table we repeat invariably. On the table we repeated the echo and we find a well-formed thrombus. So we have to postpone the procedure. Otherwise there is danger of CVA. Post-procedure echo is important again to assess for any immediate complication and to assess the results as well. Normally, in big center, you have to just inform the surgical colleague that we are doing it, please don't put any patient for half an hour. Normally we are confident enough, we don't ask for the help, but it is always very useful. You will be very confident in suggesting so. This is not written in any textbook. So we have learned that when your balloon is inside the LV, and we think that it is, I'll show you the picture later on, you are in the LV, sometimes you are in the RV through the tricuspid valve. So you have to give an LV injection from balloon to reconfirm the valve balloon position to avoid unintentional inflation in RV across tricuspid valve due to malposition. So you have to assess and be careful, and you be sure that you are in the LV, that you have crossed the correct valve and you are in the LV. And this is the first innovative procedure we learned, and my colleague call it that your technique. But the next I'll show you. During inflation, our friend Suhail Aziz, pushes a pigtail catheter into the LV across the aortic valve. So we simultaneously inflate both. This helps to delineate the mitral valve very accurately using both these techniques. So LV injection by pigtail taken and then PTMC balloon drawn and simultaneous inflation at the level of mitral valve. Normally, if you don't take the aortic pigtail catheter, so you do it blindly. When the balloon is stuck, we think it's mitral valve. But if you combine with Aziz's procedure, so you are sure that you are at the level of mitral valve. So in LAO, when the spine is on the right side and the pigtail is on the left side, you are sure that your position is right and your wire is correct and you're doing absolutely all right. This is the wire. We are sure it's correct. Its folds are all right. Now, so this is our technique, which is not written in any book. Now we are sure that we are in the LV. We are not across the mitral valve. Here, when you combine Suhail's innovation, so at the same time, you pinpoint correctly that your position across the mitral valve is accurate. I wanted to show you that Suhail's technique, but we could not load that video. So here blindly we are inflating it. In Suhail's technique, we are sure that it's at the mitral valve. We have to give simultaneous injection. So important message I want to tell our colleagues, especially the junior colleague, that PTMC should be performed in a cardiac institute, not like these days our colleagues, junior colleagues are performing procedure in a ill-equipped private labs. So why? We should not. PTMC should not, only in cardiac institute. Sometimes we need an emergency pericardiocentesis. Maybe that small lab does not have the facility. You need the help of another colleague, sometimes for septal puncture or just crossing the mitral valve. You can be stuck anywhere. So your colleague, an experienced colleague is there, patient is benefited. In AFIC and RIC both, we have been involving and we have been taking help of, in a few cases, maybe 2 or 3, pediatric cardiologists help to bail out big rent or aortic puncture, and they help us in device closure, VSD closure, and the patient was saved. So this is the benefit of doing the procedure in a well-equipped cardiac center, not in a private lab. The one thing finally I would like to say, we do lot of procedures in Rawalpindi Institute of Cardiology and Murree International Hospital on health card, free of cost. We don't have to tell our patient कि जी ज़कात से कर रहे हैं, बैतुल माल से कर रहे हैं, उसकी अना ख़राब ना हो. We say that you are entitled by the government. So we do it free, feel free to refer us. And similarly, I think AFIC was also performing, but they have to go through other procedure like CEP or maybe special location. But in our hospital, we don't have to say you are a Gharib Aadmi or we want to do it in Zakat Baitul Mal. Thank you very much.